Hello, everyone. Thank you for joining me, and welcome and thank you for attending my DNP Scholar Project presentation. My project is titled SUD and LGBTQ: Implementing the SBIRT Treatment Approach. This work focuses on improving early identification of substance use disorders among LGBTQ individuals in an outpatient psychotherapy clinic in central Minnesota. One of the main reasons why this particular group or individuals or population was chosen is because of my experience during my NP psychotherapy clinicals. And this particular clinic provide therapy for individuals within the LGBTQ population. And the owner of this particular clinic actually was focused on, or is still focused on, providing a safe space and inclusive mental health services for these individuals that are considered marginalized in the society. And while I was doing this clinical practical, I observed that most of the individuals that are coming in, LGBTQ individuals, had underlying substance use and alcohol problems. And this problem, to me, I feel they might be contributing to their mental health presentation. However, there was no standardized screening for substance use disorder during their visit at this particular outpatient clinic. And that was what led to the idea of, doing a quality improvement project to address this gap in care for this population. Several studies established, the unique risk for this population, not because they couldn't get better, but because of the societal discriminatory experiences that this population are receiving, minimizing the amount of providers or even clinical therapies that are available to help them. But before I go further, I would like to acknowledge the support of my committee members, Dr. Gail Petrov, who is the chair, and Dr. Boniface Stegman, who is the second reader. Who's the second reader? Um, I'd like to thank them for their support throughout this project. All right, my committee members, like you said, Dr. Gail Petrov, and was the chair, and Dr. Boniface Stegman, the second reader. Um, and the significance and background to the study. Like I said, substance use remains a global health crisis affecting quality of life, morbidity, and mortality rates in the United States and in the world for that matter. In 2020, SUD prevalence among individuals aged 12 and older reached approximately 14.5%. And in the same year, the US recorded about 93,000 substance-related deaths. To me, that is very significant. More importantly, sexual minority groups continue to experience disproportionately higher rates of substance use, with 15.1% of them reporting alcohol or drug misuse. This disparity is strongly linked to stigma, discrimination, and minority stress. Given this risk, this project aims to strengthen early screening practices by implementing the SBIRT approach, specifically using the CAGE-8 screening tool. And the review of the literature. And the literature consistently shows elevated substance use disorder rates among LGBTQ adults when compared with the heterosexual individuals, and this rate continues to rise. Sexual minority identity encompasses a wide range of populations, all of whom are vulnerable to substance-related harms. Based on the studies or evidences out there, individuals within the LGBTQ community, they are facing unique um, difficulties finding providers that do understand them and that would like to provide the care necessary. So the problem of, not finding the right providers with the cultural knowledge to be able to provide culturally sensitive care to them is one of the contributing factors to this problem. Again, SUD remains a major contributor to opioid-related mortality, especially following hospital discharge among, general population. The U.S. continues to face growing prevalence rates, significant healthcare costs, and increased demand for early intervention. Studies demonstrate that training mental health providers in SBIRT improves prevention efforts, increases identification of at-risk individuals, and enhances documentation accuracy. Hence, the need for the SBIRT protocol implementation. So what is the theoretical framework guiding this project? We'll look at the Dunn-Obedient model. And under this Dunn-Obedient model, it focuses on, three major elements: the structure, process, and outcomes. So this project was guided by the Dunn-Obedient framework that evaluate the structure, process, and outcomes, and how these concepts or how these factors could influence the success of this QI project. The structure component allowed for the evaluation of the clinic environment, including resources, staff readiness, and cultural inclusivity. Very important factors when serving LGBTQ patients. Like I said earlier, one of the contributing factors, to the higher risk of substance use disorder among this population is because of lack of availability of providers that are culturally sensitive to provide the care for them. And evaluating the structure and the clinic environment is very, very vital or pivotal to this project. The clinic, like I said, it's SUD LGBTQ population friendly. The owner of this particular clinic actually focuses on providing a safe space for this population and group of people in an attempt to minimize the problems that they are going through, both mental and emotional problems. And that's why we are looking at collaborating with the clinic to see how I can improve the process by implementing the SBIRT protocol to enhance substance use disorder, prevention. The process, part of this Dunn-Obedient framework, it's the component that examine how screening practices were implemented, including provider adherence to SBIRT and documentation practices. So what I did with this project was to look at what is the screening practice within this facility and how is the documentation being done. And from one of the findings that I did before I chose this project was the clinic does not have any established or standardized screening for SUD for every patient that they see within the clinic, whether heterosexual or LGBTQ. And mind you, they're not only seeing LGBTQ population, but they made the services very friendly to create a safe space for LGBTQ population. They still see heterosexuals as well at this facility. So we'll look at the screen, which wasn't existent at all, and I look at the documentation of this screening process at this facility, which were not existing at all. So I was able to work with the facility to implement the SBIRT protocol to address this gap in care to this population. And finally, the outcome components evaluated the change in screening rates resulting from the intervention. So after I talked about and I worked with the clinical director of the facility and the staff, we were able to I was able to train them on how to utilize Cage 8 screening tool. It is a component of the SBIRT protocol, which is the screening, brief intervention, and referral to treatment. So we train them, I train them on how to use the Cage 8 screening tool. And I look at the outcome after it's been implemented. And profoundly, it actually improved the screening rate after this QI intervention has been implemented. This model of framework, the Dunn-Obedient model, aligned well with quality improvements in outpatient behavioral health and ensuring a systematic approach to evaluating both the implementation and the impact of the intervention that I did at the facility. So what are the methods and design that were used for this project? Basically, this QI project used a retrospective data review. The psychotherapy clinical director extracted EMR data for patients ages 18 and 65 that were seen between the project period, that is October 24 through October 25. A retrospective approach was appropriate for this particular QI intervention or project because the project aimed to measure screening frequency before and after implementation without influencing clinician behavior. Initially, the plan was to not only increase the screening, but to kind of get data on the how many patients received brief intervention and how many patients were referred to treatment. But due to the policy at the facility and confidentiality reasons, I was not able to gather those data on brief intervention and referral to treatment. Hence, I was only able to get the screening rate, which was very clinically significant. And in addition to this, like I said, the original plan was to collect data on brief interventions and referral, but the institutional policy and consent requirement prevented the collection of those outcome measures. In addition to that, I utilized the PDSA methodology, which guided this project, focusing on the plan. The do that is after the plan has been set, the implementation, and the study, how the facility responded and what are the changes or barriers that we noticed, and act what are the changes that needed to be made before we actually finally implement it. So the PDSA plan was the quality improvement initiative sought to boost substance abuse screening rates at this clinic by training staff on using the Cage 8 screening tool. That was the plan. And what did I do? I trained the clinical therapists and staff support and on how to use the Cage 8 screening tool, following the state guidelines, that is Minnesota Department of Human Services guideline. And the screening was integrated into routine protocols for the first time at this particular clinic. And the study, this is the implementation result, which highlighted the barriers to sustaining improvements and informed potential process changes, including, staff training problems, resource allocation, and patient education. And one of the things that was addressed during this implementation was, the consent that was needed for patients to do. The staff were asking, do we need to ask for consent before we do this? Yes, as soon as the patient signed the consent to be treated, that is inclusive, but it was a little kind of causing some level of, not very strong follow through by some of the staff. But however, there was still like clinical, improvements in the screening rate. And the act was to incorporate the Cage 8 tool as part of the SBIRT protocol, which raised the screening rate from 0 that was existing at this facility before the intervention to about 44%. While this is not preventive on its own, screening identifies those at risk and supports appropriate intervention and referral. The sample, very simply, ages individuals, both LGBTQ and heterosexuals, and all gender were involved in seen at this facility. The ages are between age 18 and 65, receiving psychotherapy services. The estimate of the racial demographics include about approximately 55% Caucasian patients and 45% BIPOC patients. The clinic serves a diverse population, including the LGBTQ and heterosexual patients, like I said, which made this clinic an ideal site to evaluate disparities in screening rates and to implement inclusive screening approaches using the SBIRT protocol. Data analysis. The project used nominal data to categorize patients screened and not screened. It is not a research study, rather it is a quality improvement project, and that was why the choice of nominal, data was used. We're just comparing how many people were screened and how many people were not screened using the CAGE-8 screening tool based on the total number of people that were seen at that clinic that we received. And a z-test for proportions was used to compare the total number of patients seen during the intervention period with the number who received a CAGE-8 screening. There were a total of 223 patients that were seen, and out of these, 100 of them received the screening, resulting in a screening rate of about 44%. Though it is not statistically significant, but clinically it is very significant. Remember, the clinic was at 0 screening rate, and we're able to move it up to 44%. And while screening on its own is not the treatment, but it could set the stage for brief intervention and referral to treatment while mitigating the effect of substance use disorder. So this test helped to determine whether the intervention produced a meaningful change in practice. And what's the result? Like I said, 44% increase in screening. Yes, not statistically significant based on what we said. We set about 50% increase in screening rate at the initial phase of the project, but we are able to get about 44%. So statistically speaking, it is insignificant, but clinically speaking, it is huge, moving the clinic screening from 0 to 44%. That is very huge. So the project resulted in 44% screening rate for substance use after implementing the SBIRT protocol. Although it is not significant statistically, like I said, the p-value of 0.9382 showed that, but it is clinically meaningful. So the clinical significance reflects improved adherence to evidence-based screening practices and the establishment of a new workflow for identifying individuals at risk for SUD. This process change is an important first step toward implementing brief interventions and referrals in the future. So what are the limitations that we experienced with this project? There were several limitations to the project. First, data extraction was performed by the clinical director, which limited direct oversight and introduced a potential for errors. Second, undocumented screenings may have resulted in inaccurate totals, though preventable, but in this case, it is, we're not able to stop it because of the process of the QI project. And third, the reliance on manual EMR reporting could introduce reporting bias. And finally, the limitations in consent policies prevented collection of data on brief interventions and referrals, which could have provided a more complete evaluation of SBIRT implementation. And for future, studies, this will be a good, data to actually look into after getting the IRB approval to do that. And the discussion. SBIRT improved early identification. That is established based on what we did over here, implementing the CAGE-8 tool as a as part of the SBIRT protocol. It actually improved early identification of substance use disorder by doing the screening, increasing the screening from 0 to 44%. Remember, at this facility, there was a 0 screening being done, and 44% of them were screened based on the total number of patients that were seen within the period of intervention. And to me, that is very clinically significant. And without the screening, you will not be able to identify somebody with a risk. So screening is the benchmark, is the starting point for us to be able to identify. And when we can improve the screening rate, there is a possibility that we can actually, provide brief intervention and referral treatment and identify individuals at risk. And like I said, the screening increased from 0 to 44%. And this project actually helped to, improve the clinical workflow by laying the groundwork for more targeted interventions, better care coordination, and improved health outcomes for at-risk individuals or the populations. So what is the implication for practice? Implementing SBIRT aligns with the guidelines from the Minnesota Department of Human Services, the CDC, and the SAMHSA. And these are organizations that are focused on mitigating the effect of SUD, both at the individual and the community level. The project highlights the importance of early screening in preventing progression to more severe substance use disorders. Consistent use of SBIRT can improve patient safety, enhance provider awareness of SUD risk, and strengthen preventive care within behavioral health settings. Ultimately, it supports a more proactive and patient-centered approach to care. And in conclusion, just basic roundup, SBIRT implementation, this project improved SUD screening rates among LGBTQ patients by implementing the SBIRT using the CAGE-8 screening tool. While statistically not significant, the clinical improvements reflect meaningful progress in early detection. If this study is repeated, what I would change is I would incorporate provider training, more training, automatic EMR prompts that will remind providers to do the screening, and consent processes for collecting intervention data like the brief intervention and referral to treatment. And what I've learned so far from this is that this DMP journey has strengthened my leadership, advocacy, and quality improvement skills. It has reinforced the role of the DMP prepared nurse in influencing policy, promoting health equity, and advancing evidence-based practice. And at this junction, this is the end of the presentation. Thank you so much for listening and have a wonderful day.